אני אציג לכם את העורך שלנו היום, פרופסור ג'ון הרצנברג, שהוא המורי. אני בדרך כלל לא אומר הקדמות של 10 דקות, אבל אני חושב שחשוב למי שלא מכיר את ג'ון, שהוא אגדה בעולם האורתופדי, לא רק אורתופדי ילדים, אגדה בעולם האורתופדי. ג'ון נולד לפני 69 שנה, ואצל זה סבא וסבתות שבאו ממזרח אירופה וגרמניה, והוא היה צעיר משלושת ילדיו. זה אמא, אבא נלחם במלחמת העולם השנייה, וככה הוא נראה בגיל 15. אי אפשר לראות את הקרחת שלו ולהאמין שהוא ככה היה בגיל 15, ובגיל 15 תחשבו רגע, האיש מחליט לעשות 3 שנים בכפר בלום, שזה לפני המלחמה, וככה היה נראה. זה תעודת גמר, זה תעודת מחזור. מי שהשפיע, מה שהוא אמר עליו, מי שמשפיע הכי הרבה עליו בתחילת קריירה, זה מנהל מחלקת אורתופדיה בעפולה, אבלסון, שחברת כיתה של ג'ון הייתה בקיבוץ. אני לא יודע אם זה fortunately או unfortunately, אבל הוא עזב את הארץ לפני מלחמת יום כיפור, והגיע לבוסטון. אם אני נשאר בארץ, ג'ון, אולי היית מנהל אורתופדי ילדים ברמב"ם. אבל ג'ון עשה בוסטון, וזה עוד מורה שלי, שהוא אחרי מות של אליזרוב, הוא אליזרוב של ימינו, דרור פלא, הם ביחד עשו בסיקיץ את הפלושיפ, וביחד הם הקימו מקה של לימב לנסינג ודיפורמיטי קורקשן, וגם אורתופדי ילדים, בהתחלה בקרנן, ואחר כך בסיני הוספיטל בבלטימור. עכשיו, זאת אישה של מריל, 3 ילדים, 2 מהם אחיות. ג'ון הוא סיפור שהיום אמרתי לו, למה הוא עכשיו גר בקולורדו, בבולדר בקולורדו, למה אתה לא עושה יום אחד בדנבר למשל, כן? כי אי אפשר כזה דבר, הוא אומר, אני פעם אחת בחודש נוסע או לליבריה או נפאל או לזה. ג'ון הוא נוסע בכל העולם באופן קבוע. פה זה עם דניאל. התרומה הכי גדולה של ג'ון באורתופדיה ילדים זה קלאפות. הרי אתם יודעים, פעם נתתי לכם הרצאה שקלאפות אנחנו ניתחנו, אני ופרופסור ביאליק ניתחנו כל שני וחמישי את הילדים. אנחנו בכל העולם מזמנים של היפוקרט. ופונסטי זה שעשה מהפכה בקלאפות, הוא היה גאון, אבל אף אחד לא שם עליו שם באיובה. עד שג'ון התחיל לעשות פופולריזציה של השיטה. ויום אחד הוא שאל אצל חבר שלו מאיובה, פרידיץ, האם זה נכון שבקלאפות לא מנתחים באיובה? כן, אנחנו עושים שיטת פונסטי, אני יכול לבוא ולראות איך אתם עושים את זה? הוא אומר, שמע, לא כל שבוע יש לנו חולים עם קלאפות, אנחנו נשלח לך ספר. ככה הוא קרא את הספר ממה שהוא כותב, From Cover to Cover. Suddenly I was finding that the clawfoot I was seeing were responded beautifully to the Ponseti method, all need tenotomy, but virtually none need extensive traditional posteromedial release. This was clearly a game changer. To this day I look at my most significant achievement was to help jumpstart the spread of the Ponseti method worldwide. וג'ון זה פשוט עשה לנו מהפכה מ-2003, אני ניתחתי 3 קלאפוטים, כמו אז, וזה היה בתחילת ככה זה הייתי ב-2002, וכל יום שישי הייתי הולך וללמוד איך ג'ון עושה. ככה זה החבר שלי לקח אותו לרמת דוד, ונשב ב-F-16 בקוקפיט, ממש בסדר. כשאני פגשתי אותו בבלטימור, אז הוא היה ספורטאי על, ואחרי שהוא לחץ לי את היד, הוא שאל אותי באנגלית איזה ספורט אני עושה. אני הייתי עושה, חוץ ממד קסיס, לא זוכר אף אחד, אני הייתי חייב סמוקר, כזה בטן, 20 קילו פלוס, שום ספורט לא הייתי עושה, אבל בגלל ג'ון התחלתי לעשות גם את הספורט. אני ניתחתי עם ג'ון פעמיים באקוודור, באוגנדה ובאתיופיה, ותסתכלו פה על הילדה הזאת. תסתכלו עם איזה בעיות הוא מתמודד במישן. תסתכלו איפה הרגל שלה. כן, אתה לא תופס את זה בהתחלה. זאת מריק דלביץ' כאן, שהייתה הפלו שלנו פה, שהיא אורתופד ילדים הכי טובה בעולם, וזה באוניברסיטה של מרלין. ככה זה באקוודור. פה זה אני עם נועם בור באקוודור ב-2011. זאת מריל. רק תחשבו רגע שאישה יהודייה נוסעת, היא פרופסור בסיעוד באוניברסיטה of מרילנד, נוסעת לפקיסטן כדי להתנדב שם אחרי אסון. ג'ון הוא טופ 3 באליזרף מתוד בעולם הערבי. ובן אדם עשה לגאסי. זה מה שהשאיר אחריו בבלטימור. ועכשיו הוא גר בדירה סחורה 3 חדרים קטנה בבולדר בקולורדו, ועוזר לבת, זה לגדל את מאיה. תסתכלו פה, זה עכשיו בנפאל, עכשיו הוא עובד 3 פעמים בשבוע במפעל של החתן שלו בריפטון, כולנו עם הג'קטים כאלה, עם הכובעים של הריפטו כאלה, והוא גם מומחה. זאת מאיה מסתכלת על מפה של ארץ ישראל, והוא גם מומחה עולמי באיסוף ביצים. פעם שעברה שהיה בפברואר היה נוסע לשומרה, ו3 ימים עטף את הביצים יחד עם התאילנדים. נראה לי את הסרטים, הוא עושה את זה הכי טוב בעולם. ואלה המתמחים שבמשך הקריירה עשו את זה בבלטימור, וזה בבית שלי, כן? זה בבית שלי, פה זה דורון ורובי, ואפילו בג'קוזי הוא נותן לנו הרצאות על אורתופד ילדים, איך צריך לעשות. טוב, ג'ון, עכשיו ספר אתה מה אתה יודע על ה-torsional deformity.
I promised Mark I'd give the lecture in English so it would go faster. And I'm going to talk about a very mundane topic, nothing fancy, Star Wars, Elazarov, external fixation. But I'm talking about the kind of thing that you as pediatricians will see in your office every day. And you're going to scratch your head and say, should I send this to the orthopedic surgeon or can I treat it myself? So, and these are torsional deformities, kids who either toe in or toe out. You bet we see them all the time, but hopefully after this lecture you won't send them to us so that you'll take care of them yourself. So, 3 things that can cause a child to toe in or toe out: metatarsus adductus, internal tibial torsion, and femoral anteversion. So we'll go through each of these 3 diagnoses one by one. There's some terminology. When we look at children walking, we're doing a mini gait analysis in our head. We create something called the torsional profile. And it consists of the foot progression angle, which way the feet are pointing, either in or out. And then on our physical exam, we look at what the hip rotation is doing, how much internal versus external rotation. And on the physical exam, we also look at the thigh-foot axis, which I'll illustrate all of these things with pictures. So we look at a child walking, and we're looking at which way the feet are pointing, and then when they sit down, we examine them and look at how the tibias are pointing, and then we examine them both supine and prone, and then we put all this together and we develop a torsional profile. So this is an early example of gait analysis with photography. Now, of course, gait analysis is done with computers and digital, but the truth is you don't need a fancy gait analysis. You can do this in your head. So foot progression angle refers to footprints on the ground. Either the feet are pointing straight forward, or they're pointing outward, or pointing inward. And this has a tendency to change with age. So it doesn't change a whole lot, but it does change with age. And we have to remember that when we're looking at children. So we take all this data and we develop in our head this summary, which is the torsional profile, taking the child walking, examining them prone and seeing how much the feet turn out compared to the thighs, how much the hips rotate in versus rotate out. And all this is based on physical exam. You don't really need CT scans, ultrasounds, tests, x-rays. It's all a physical exam based study. And in the literature, there are studies that look at how much rotation inward and outward is normal at different age groups, because it does change. And so we kind of have to have this information in the back of our head as to what the normal variation is. And then if you're outside the normal variation, then we talk about, maybe some kids need treatment, but the vast majority don't. If you ever see asymmetric findings, one foot's turning in, one foot's not turning in, that's something that should pique your interest. And then you look at the parents, because the apple doesn't fall far from the tree, usually. And so you have to, see how the parents look and how they walk sometimes as well. No, just a picture. So the first thing we talked about is metatarsus adductus. This is a disorder of the foot itself. And this usually corrects very spontaneously. If you see a child is born with a kind of a bean-shaped foot, and if you treat it early, it's usually very effective, within the first few months of age. It can be treated with either casts or braces, or sometimes just by doing stretching exercises. And this is what I call a packaging problem, not a manufacturing problem. In other words, this is not a birth defect, but it was a big baby in a small space, and it was shrink wrapped. If you wrap them really tight, it will cause the feet to turn in. So, and I explain it to the parents in these terms, that we're talking about a packaging problem, not a manufacturing problem. But parents are very invested in their child's feet. This is my niece, many years ago. Now she has twins of her own. But this is the birth announcement, the little perfect feet that they made the footprints of on the birth announcement. We use something similar to document how much the feet are turning in. So when I see a patient in my clinic, you can paint the foot with betadine, or you can take a digital picture now, whatever you want, and this gives you a baseline of how much curvature there is to the foot. There are other things that can cause this. So in your differential diagnosis, a very serious thing would be a club foot that requires aggressive treatment. There's something called an atavistic great toe, where the toe muscle is just strong and it pulls in like we're trying to climb trees. And a skew foot is another rare deformity that you have to recognize. And so if something doesn't quite fit and it's not correcting, then that should prompt you to refer the patient to the pediatric orthopedist. And of course, neuromuscular disorders like cerebral palsy or spina bifida can sometimes present with foot deformities. So if you see some of these more serious conditions like clubfoot and skew foot, then those demand referral. Like anything, you can put numbers on these. You can be scientific and you can say, well, it's a bean-shaped foot, but how much of a bean-shaped foot is? So the way we measure this is we use something called the heel bisector. You draw an oval on the heel, bisect the oval, and where that line intersects, toe number 4, 5, 3, 2, 1, is how you define it. So this one would be 4.5. It's between toes 4 and toes 5. So if you're doing research, which basically nobody except me ever did research on metatarsus adductus, it's the only prospective randomized clinical trial that I ever did in my career in orthopedics was a prospective randomized clinical trial on treatment of metatarsus adductus. But I'll show you that later. Treatment can be stretching if you have metatarsus adductus, so I teach the parents how to stretch, and I give them a month or 6 weeks to do this, and then I have them come back. If it's not better, then we'll either do casting of the foot or some special kinds of shoes that keep the feet turned out, and usually within a month or so that takes care of it. Here it is, my only prospective randomized clinical trial. It wasn't double-blind, but it was pretty good scientific study, and we showed that casting and orthosis had similar outcomes. This is an Israeli patent. There's a company here that's marketing this called Unfo. Mark has published 2 papers on this, I think, already. And we started using it in the United States, and it works pretty well. Sometimes the kids have trouble keeping it on the foot, but overall it's not bad, and it's certainly a lot easier than casting the foot. And this is one of my patients back in the United States. We applied this Israeli device, the Unfo. Surgery for metatarsus adductus is very rarely done, and when it's a distinct diagnosis, and usually in older children who are resistant to casting and braces. We rarely see this in premature babies because they don't get big enough to be crowded. So we don't see dislocated hips so much in premature babies. We don't see metatarsus adductus. All these diagnoses that are associated with crowding, intrauterine crowding, don't happen so much in premature babies. Now, our parents, I've seen it just from my interactions in the clinic here with Mark's parents. I think Israeli parents are especially crazy when it comes to their children and what's good and what's not good and what they should do. And the companies have bought into this nervous feeling, and so they make all kinds of shoes for kids of different ages. And if you don't get the right shoe for the right time, you're not being a good parent. So you can go to pediatric shoe stores, and they'll say, well, step 1, step 2, step 3, and where's my child? And it's all nonsense. All of it. It's all hocus pocus. And they try to make some science of it, and they give you pressure studies, baby tech versus barefoot. And so if you want your child to keep up with the other kids, oy vavoy if you don't give them the latest fancy shoe. But the real purpose of children's shoes, and you can tell this to your patients, why do we wear shoes? The real purpose is to protect our feet from the environment. That's it. We have an environment where there's needles and rocks and sharp things, and that's why we wear shoes. Children grew up without shoes for hundreds of thousands of years before we invented shoes. I do tell the parents that high tops, the bigger, taller shoes stay on better. Make sure that they have a wide toe box, basically a sneaker. All right, so that's metatarsus adductus. The next cause is that we go up the leg. We talk about internal tibial torsion. And internal tibial torsion is demonstrated in this child whose knee is pointing forward, but the foot is pointing in. So there's a twist along the long axis of the tibia. And it may be related to sleeping position. It's also related to how the child was folded up inside intrautero. And most of these will improve spontaneously, but it creates a lot of sleepless nights for parents and grandparents while they worry about it. The way we measure it and test it is we put the child in the prone position, bend the knee 90 degrees, and then a bird's eye view, look directly down onto the foot. You can draw an axis that represents the foot, and you can draw another line that represents the back of the thigh, which really what we're looking at is the perpendicular to that, which represents the knee joint. So the relative orientation of foot versus knee determines what your torsion is of your tibia. So your foot may be pointing way inward or maybe way outward, and that would give you either internal or external tibial torsion, and you can measure these angles. You can estimate or use a goniometer to measure it. There have been studies that show that you can measure these things with CT scan, ultrasound, fluoroscopy, but I never, ever, ever do any of those tests. This is strictly a clinical examination. So why do kids get this? I mean, we know that in utero they're in this tight position, but some of these children continue that tight position extra utero after they're born. They'll sit in this position they're sitting on their feet, so they're just recapitulating the fetal position and making it harder for this to correct on its own. So in dealing with this, sometimes the treatment for it, in my practice, and I'm not universal, but in my practice is to give them a nighttime sleeping orthosis. So what does this do? If you put this on the child before they go to bed, one of two things is going to happen. Hopefully, what will happen is it'll prevent them from sleeping in the bad position. It prevents them from recapitulating the fetal position. The second thing that can happen, the bad thing, is that it prevents them from sleeping. And then the parents are going to be very unhappy. So I tell the parents that these things usually get better, but if you want to treat it, we can do this. But I have to warn you, some children who are a year and a half, 2, 3 years old, if you put this on them, they won't sleep at all, and then of course everybody's unhappy. It's interesting, years ago, there's so many smart people here in Israel, but an Israeli company came up with a articulated boots and bar device that allowed the child a little bit more mobility and yet still kept their feet at that externally rotated position. I don't know, Mark, if this is still available here, but this was from their advertising material. And of course, they were comparing the old rigid boots and bar with their new mobile boots and bar that allowed the children, which one of these two kids is going to succeed more in life, and which one is going to fall flat on his face because he's using the old technology versus the new technology. For some reason, I think that company must have went out of business because I haven't seen it, tried to get it, but I'm happy I have the picture to show you. Another device that you can make is a knee ankle foot orthosis. The advantage of this device that the girl has on the far screen is that you don't have to tie the 2 feet together, and so they're a little bit happier. If you want to make a child really unhappy, they have all kinds of devices. This one was for bow legs. That I don't know who would sleep with that thing on. And then rarely these things don't work and we have to do surgery, which is usually an osteotomy just above the ankle, where we cut the bone, tibia, and sometimes the fibula as well, and rotate it, turn it outwards, and let it heal in the new position. So this is how I do that surgery, and again, this is not commonly done. The vast majority of kids who have tibial torsion don't need any surgery, but I am a surgeon, so I have to show you some surgery. You have to do something. So we like to do things controlled. So we put on an external fixator and cut the bone, turn it, and then put on a plate, and that holds it in the exact position we want it while it heals. You can cut the fibula or not cut the fibula. There's two different schools of thought. Then I put on the external fixator and cut the bone and use the external fixator as temporary fixation to hold it in the exact position, because if you're trying to rotate something from 10 degrees in to 15 degrees out, that's a 25-degree correction. How do you hold it and then put the plate on at the same time? So we found that if you put on the external fixator, it holds it exactly, and then you can very carefully put on a plate just the way you want to do it. Here's the plate going on. And then once the plate is on, then you take the external fixator off, so the family and the child never sees the external fixator. The only thing left is a hole where the external fixation pin was. So that's tibial torsion, and I don't want to leave you with the impression that we operate on them a lot. This is very rare, but I have to show you the surgical treatment as well. The next thing up, and this is hardest to explain to parents, hopefully not to doctors, but is femoral anteversion. Femoral anteversion refers to a torsional issue in the thigh bone, in the femur, instead of in the tibia. This is a typical diagnosis made between 2 and 4 years of age. And once again, if you recapitulate the fetal position, it can accentuate the deformity and make it harder for it to correct. Bracing has been shown to be 100% ineffective, and surgery, if you do it, we wait until age 10 or 12 at least, because so many kids will improve spontaneously. We don't want to do an operation and take credit for fixing something that would have gotten better on itself just naturally. So again, you can test this with X-ray, CT, ultrasound, but I never do that stuff. I only rely on my clinical examination. And this young fellow his legs are turning way in. And by the way, there's going to be a test at the end, so you got to watch carefully, because I'm going to test you at the end for what the diagnosis is. So this is how we do it. This is, and all the pediatric orthopedists, orthopedic surgeons in the room know that when we examine a child, we put them prone on the table, and then we move their legs in and out as if they're the arms of a goniometer. How much does the leg turn in? How much does it turn out? And that's the amount of our femoral torsion. Now, most people will turn in 45 degrees, out 45 degrees. But you get some kids who turn in 60 degrees and out only 10. So they have a much higher tendency for internal torsion of their femur. And in the same position, we look at the tibial torsion. But this is showing you the example of an extreme case of internal femoral torsion. Has very little external, but a lot of internal torsion. And so we simply record this in numbers. You can either estimate or use a goniometer. So this kid has internal rotation like 90 degrees. His feet almost go flat, but external rotation only about 10 or 15 degrees. So the diagnosis for this one, for those of you keeping score, getting ready for the exam, is internal femoral torsion. And if you put him over on his on his back, this is the child who sits in the dreaded W position. Why do we call it the W position? Because when he sits like this with his legs internally rotated, his legs look like the letter W. So the diagnosis here would be internal femoral torsion, femoral anteversion. And if you do that same exam with the child supine instead of prone, you can see that his legs will turn almost backwards and his kneecaps are kissing each other. And we go to turn the legs out, they don't go out so far. So this is femoral anteversion or internal femoral torsion. And where does it all come from? It really comes from the direction that the femoral neck is coming off of the femur. So here you have three situations where you have a very anteverted neck on the far end, a normal one, and a retroverted neck. So this guy is going to have a lot of external rotation. This guy is going to have a lot of internal rotation, and this guy is normal. So it's hard to explain this. It's hard to explain to doctors, but it's even harder to explain it to parents. But this is really the difference between, someone who has internal, external femoral torsion, and it has to do with impingement against the acetabulum. The far one has to travel a long distance before it impinges against the acetabulum. This one, not very far. So it has to do with the orientation of the acetabulum relative to the femoral neck. The amount of femoral torsion does change as you get older. In young kids, they're born with a lot of internal femoral torsion, and then it spontaneously improves up to around the age of 10 or 12. So if you are contemplating surgery for this, it makes sense to wait until they're at least 12, 14 years old and let it correct on its own. There's been a couple studies that look at what the effects of different types of bracing, twister cables, Dennis Brown boots and bars, plus or minus both, and the amount of improvement was no different with any treatment. So basically, nobody that I know treats this with any kinds of bracing. So if you do have to treat it, and it's not common, then we do an osteotomy, either proximal femur, which is what I prefer. Some people do distal femoral osteotomies, and in the old days they would just cut it, turn it, and put it in a cast. Nowadays we use internal fixation. So I like to be accurate, I like to be scientific, so we developed a method called fixator-assisted subtrochanteric derotational osteotomy. It's indicated for femoral retroversion, anteversion, and the so-called miserable malalignment syndrome, which we sometimes see in our office. These are kids whose feet turn in but their hips turn out, and it causes strain on the knee. I think I'll just illustrate how we do this. We do a proximal osteotomy because it heals best and it doesn't lead to knee problems as far as tracking of the patella mechanism. So if we want to be safe, we cut the bone high near the hip. If you cut the bone low near the knee, you can cause some disturbances of the tracking of the patella, which then creates knee problems. So I would say that 90% of the time we're doing the osteotomy near the hip. And so what we're doing by doing the osteotomy to the hip is we're changing from this situation to the middle, or from that situation to the middle. We're just trying to make that 30 degree or 40 degree difference in which direction the femoral heads point to control the rotation. It all goes back to our physical examination of the child. How much internal rotation, how much external rotation. So when you're done with the surgery, you expect your exam to change as well. So here's just a step-by-step how we do the surgery, because I know we have half the audience as surgeons, so they want to see this. The other half is pediatricians, so they're going to go to sleep when I show you pictures of drilling holes in bones. But we start by venting the canal. This is for this half of the room. We vent the canal so they don't get excessive pressure. The starting point is in the greater trochanter, because we don't want to get avascular necrosis by damaging the blood supply to the femoral head. So we have a very lateral starting point. And then we use first a Steinman pin and then an ACL reamer to gain access. Then we put down the beaded guide wire, and then we do the reaming. The reamings will exit at the drill holes. That provides pre-positioned bone graft, so the osteotomy is going to heal faster. It also decreases the risk of fat embolism from reaming a closed canal. With the guys in Ichalov, we're just now publishing a study comparing venting and non-venting, and neither group actually had the problem of fat embolism, but the healing was much faster when we vented, the venting group. So the next thing we do is before we cut the bone, we vented the canal, we haven't cut the bone. Before we cut the bone, we put on a pin proximal and a pin distal to represent the current torsion of the femur. And that way we have some kind of control mechanism to measure exactly how many degrees. So we go into surgery with a plan. You want to do a 30 degree derotation or a 20 degree derotation, and then how do you execute that plan? There's a problem in orthopedics that I can draw the fanciest plan on paper preoperatively, but can I execute that plan in the operating room? So there's a saying that in orthopedics, we measure with a micrometer, we then mark with chalk, and then we cut with an axe. So at every step we can measure with a micrometer, we can be very accurate. Then we mark it with chalk, well, that's not so accurate, and then we cut it with an axe. So that's every step of the way you're losing some degree of accuracy. So this is an attempt to maintain our degree of accuracy. So we put a special way these wires are put in, because we have to stay outside the passageway of the intramedullary nail. So start with a K wire, check it on x-ray, see where it is in the lesser trochanter, and then we ream over that with a cannulated drill, and then put in a stout pin, not a thin one, but a 6 millimeter pin that's not going to bend when we rotate the leg. And then distally, we're beyond the pathway of the nails, so distally we put in another pin. And then if you look at how you put those pins in, they're put in to represent the angle of how much you want to correct. So let's say we decided in this case we're after a 30 degree correction. So we have one pin going in, the other pin going in, and if I've done it correctly, if that's what I want to get, there should be 30 degrees. Let's say I did it incorrectly, there's 35. Well, when I finish, I should have a 5 degree angulation between these pins instead of parallel to each other. But this is where the accuracy comes in. And then once the pins are in, we can complete the osteotomy, and now we know we just have to make those two pins parallel to each other. And so then we make them derotate the bone, make the pins parallel. They started at 30, now they're 0, and then we put in our nail. We can hold that orientation with an external fixator on those two pins. We finish the reaming and put in the nail, lock the nail, and once the nail is locked, then we remove the external fixator. So the external fixator was really, I call it the iron intern. It's the intern who never gets tired, never complains, never falls asleep during surgery, and he does exactly what I tell him to do. I say, hold this bone at 30 degrees. Yes, sir. And he holds the bone at 30 degrees. Of course, that doesn't exist. But it's nice to know that you guys have been replaced by an external fixator, right? So doesn't get tired, doesn't complain, does a good job. And anyway, so then you take the fixator off, and the patient wakes up and doesn't feel or see any fixator, but there was one that was in there temporarily. So here's a clinical case, starting point at the greater trochanter, and this is stuff you guys do every day, so we know about this. But this is very careful. You have to avoid it damaging the blood supply of the femoral head. So this is the part where we use a lot of C-arm and make sure we're not poking around on the neck of the femur where the lateral femoral circumflex artery runs. And we know that that wire is behind the pathway of the nail, so we can put our X-fix. We've proven here with an X-ray that the X-fix pin is outside the pathway of the nail. And then we do our derotation. There's a distal pin, locking, and there's the final X-ray output. So you can do both sides at the same time. It's a little bit of an increased risk of fat embolism if you're doing two femurs the same day, but you can vent the canal to decrease that risk. That's what it looks like at the end. So external fixation assisted technique allows you to be accurate, and you can do the exact amount of derotation that you plan based on your physical exam preoperatively. So in summary then, the treatment for these torsional problems, we have metatarsus adductus, the bean-shaped foot. Usually we treat that in the first 3 to 6 months of age before it becomes stiff. ITT, internal tibial torsion, if it's greater than 15 degrees off from normal, we'll wait until about age 8 before we operate on that, because things often get better by themselves. For femoral anteversion, we usually wait until 8 to 10 years of age before we treat that, because again, things will often get better by themselves. Okay, who's ready for the final exam? All right, so I'm not going to embarrass anyone by calling on names, but this is a famous football player at the University of Michigan, Anthony Carter. What's his diagnosis? I mean, he's in-toeing, right? He's got excessive in-toeing. So is it coming from his feet, his knees, or his hips? Is anyone brave? Just shout it out. Hips. Hips, okay. Femoral anteversion. So if his whole leg is turned in, that means his knee's also going to be turned in. And so it's coming from the hip. So we think he's got femoral anteversion. And some people think this gives runners an advantage. And in fact, here's a little picture of a gnome from a gift shop, and in the bottom it says the feet are slightly turned in for advantages in running over rough ground. So that's the proof. Okay. Can anyone read the number? Can anyone not read the number? 10% of men are colorblind. So you all see the number 5? Okay, you passed the test. Okay, that was easy. Okay. All right, the back of a cereal box. Here's a guy just won the race. What's his diagnosis? Same. I mean, it looks to me like his patella is pointing in a lot. So he's got a lot of hip rotation, and yet his patella and his foot are kind of pointing in the same direction. Yeah. Okay. I'm going to call it femoral anteversion for this. All right. What's wrong with this child? Look at his right foot. Let's concentrate on his right foot. There's his knee. There's his foot. What's his diagnosis? Internal tibial torsion. אתה אסור לך להגיד. Mark.
We have a war.
Okay. Okay, all right. So this is internal tibial torsion. All right. What's this one? Doron. On the right. Well, that's advanced. This is the beginner lecture.
Femurs are in for sure, but the other facing forward.
Well, from the knee down, what's wrong with this one?
External tibial.
Right. The knee is pointing forward, but the foot is pointing out, so it's external tibial torsion. This is our femurs. All right, Doron.
Combination, I think. Super inward femoral introversion and interinversion.
So it's hard.
For sure.
It's hard without seeing it, but definitely femurs are turned in. So she's not going to be a star in the ballet class because she doesn't have natural turnout. Okay. One of the other mitmachim. What's wrong with this child? What's the diagnosis? I'm trying to turn the feet out and they're barely turning out. But when I try to turn the feet in, the kneecaps are kissing each other. So answer? Femoral anteversion. Okay. Okay. What's the diagnosis? This is the dreaded W position. So the hips are turning in a lot. They don't turn out. And she sits this way because this is the way it's easy for her to sit. So another femoral anteversion. We'll skip this one. Okay. Doron. I don't know. It's a totem pole. No diagnosis. Okay. So unfortunately, these kids don't come with an owner's manual, and so it's our job to figure it out and make these diagnoses. I hope that this short lecture has made it easier for you and not more confusing. Thank you.
Thank you very much.